Hello, and welcome to the Sound Health Network's webinar series. I'm Indre Viscontis, your host and moderator for today's event. The Sound Health Network is led by co-directors Julene Johnson and Charles Lim, who also composed our introductory music. And music therapist Sherry Robb and I round out the leadership team. Our mission is to promote research and public awareness about the impact of music on health and wellness. The Sound Health Network is a partnership of the National Endowment for the Arts with the University of California, San Francisco, in collaboration with the National Institutes of Health, the John F. Kennedy Center for the Performing Arts, and Renée Fleming. Please feel free to introduce yourselves if you're live with us in the chat, and you might also post questions there that we will take towards the end of the webinar. This webinar series features interdisciplinary conversations between researchers, music therapists, and other stakeholders in our community that represent diverse perspectives and address obstacles that stand in the way of our mission. This month, we're focusing on how music therapy can help people manage their pain. Our panelists include Joke Bradt, professor and director of the Ptsd program in Creative Arts Therapies at Drexel University. Welcome, Joke.
Thank you.
She is a board-certified music therapist, and her federally funded research program has focused on music therapy interventions for chronic pain and chronic illnesses. She's recently completed 2 NIH-funded trials, which we will talk about, one on music therapy for chronic pain management in people with advanced cancer, and one on music therapy for chronic pain management and opioid tapering in cancer survivors. She's also currently conducting a study funded by the National Endowment for the Arts on music therapy for chronic pain management in service members with chronic pain and comorbid mild traumatic injury. Our other panelist is Maya Story. Hello, Maya, who is a music therapist and an investigator at the VA Health Services Research and Development Services Center for Health Information and Communication. That's a mouthful. I hope I got it right. Her research has involved the use of music and imagery for veterans with chronic pain and with PTSD. Her other research interests include the integration of arts and health and wellness in everyday life, as well as the use of telehealth for creative arts therapy. Thanks so much for joining us. So I would like to start with a kind of overview of the patient experience, the kinds of patients that either Joke, your research helps understand how music therapy might help, and or that Maya, you work with directly. So Joke, can you tell us a little bit about the kinds of patient groups that you've been most familiar with?
Yeah, first of all, thank you so much for having us, Indre. So happy to be able to share our experiences about this important topic. So most of my research has, of course, focused on chronic pain, but with different types of populations. So as you mentioned in the introduction, we've been doing some research with my lab in focused on chronic pain management in people with cancer. And actually the NIH study that we just completed was focused specifically on people with advanced cancer who also have chronic pain. And we've also just started expanding our research to the cancer survivor population, because many of them are left with chronic pain after living with cancer. In addition, we have done research in non-cancer populations. So people like you and me who have chronic pain and all kinds of chronic pain, not particularly focused on one type of chronic pain. And just recently, we started a study with active duty service members who have mild traumatic brain injury as well as chronic pain. But I also want to mention that we have been doing some research focused on the use of music therapy for postoperative pain management, specifically in people with total knee replacement, but with the focus of looking at their immediate pain management, but then the impact of helping them with their immediate pain management through music therapy, looking at how that might impact their immediate opioid use as well as long-term opioid use.
Well, that seems particularly interesting to me since I just had shoulder surgery 3 weeks ago and dealing with a lot of pain. So I would love to see how music therapy might help in addition to the PT. So Maya, tell us a little bit about your patients, the patients that you work with, and maybe even a situation in which has stuck with you in terms of how music therapy has been effective.
Sure. I'm relatively new to working in chronic pain. My research with chronic pain began about a little over a year ago and was the result of a mentor I've been working with at the VA Medical Center, Matt Baer, who's a general internist and a clinical trialist who does research in chronic pain, especially with non-pharmacological interventions for chronic pain. So he and I joined up for the recent study that we're on. Previous to that, though, I worked with women veterans with PTSD. So I have been working with veterans for about 12 years, and both clinically and in research. And it's interesting because there are many veterans with chronic pain who also have PTSD. So there's a lot of comorbidity that goes on. But I can share a recent experience with someone who I was working with who had chronic pain. And I was using the music and imagery process that I'm trained in. And it has this, in the beginning, it has this psychoeducational component about how to use music to regulate emotions or to regulate physiological things, pain. And then later, it's more about exploring one's relationship to pain and gaining different perspectives on that relationship to pain because, right, chronic pain is a long, ongoing thing. So one of the goals is to be able to continue to function and participate as much as you can in your daily activities along with the pain. With this oh, go ahead.
So I was going to say, recently I had the opportunity to talk to a physician named Hedder Verreich, who just wrote a book called The Story of Our Pain. And he really talked about the fact that, for a lot of people, pain is just going to be a part of their lives. And if the goal is to get rid of the pain, there's always going to be disappointment. But instead, he was saying that the field was moving towards this idea of how can you regain as much of your quality of life, even while still, the pain is present.
Right. Absolutely. That goes in perfect with the story I'm going to share too. So I'm glad that you said that. So with this process, there's a check-in in which you really focus on the here and now. And that's in order to kind of activate that sort of need for self-care. So whether it's the pain that you're dealing with in the moment or whether the patient is dealing with anxiety or depression or mood things, insomnia, other things that can be related to the pain. But figuring out what is up for them in the here and now, and then what they might need to help with their self-care related to music. So then we choose music together and listen to it together. And then there's an integration. So that's the process. But for this particular veteran, he came in and he was very frustrated with this journey with pain and his body and had an image of sort of the slow process of like rebuilding his body so that he could function in a better way. And he had this image of a bridge being built. And he said it takes time and it takes community and it's a really long process. So we brought in some music that he chose that could kind of enhance that image. And he chose two very different types of pieces. One was a very slow meditative piece that you can imagine. He imagined some Tai Chi type of movement too. And the other was a very motivational piece. It's actually from the movie The Transformers, a piece called You've Got the Touch. And it has a lot of high energy and So these were two different solutions for him in the moment, but we worked together to find what was going to be the best solution for him that day and in that moment. And he chose the Transformers piece, the You've Got the Touch. And we listened to it together and talked about it and how it interacted with the imagery and his images. But he said, you know, pain doesn't have to be my centerpiece. And that was a really big message for him and speaks to that, the idea of like pain being the center of your life. But what if it doesn't have to be your centerpiece?
Yeah, I mean, I think that that's sort of what pain is so complicated because it's subjective. There isn't really a biomarker, especially for chronic pain. Maybe inflammation, you could argue, or, you know, for acute pain, there's maybe some evidence, but even that is very, you know, like a burn victim, for example, the more severe it is, the more nerve damage it is, there's zero pain. So, you know, there's this relationship that has so many layers. And it makes me then, you know, sort of wonder how we got to this place, especially in the US, where there's just this notion that you go to the doctor and they give you a pill and that makes the pain go away. And certainly opioids and other painkillers are very effective. But of course, there are lots of problems associated with that. And, you know, Joke, a lot of your work is focused on opioid tapering. And I wonder if you could speak a little bit to this issue and the fact that so often people who experience some kind of trauma or surgery and are given opioids are not also then taught how to taper down from them.
Yeah, I think, of course, the problem with the opioid crisis in the US is very complex, and we certainly don't have time here to uncover all of that. But I think there's a couple of crucial things that you already touched upon. One is that people go to the doctor really expecting to get a pill to take care of the problem or for the doctor to find a solution. Hand in hand with that goes the fact, which I've heard now repeatedly, is that in medical training, there's actually very, very little attention paid to pain management. So apparently a really small percentage of the training of medical doctors is focused on pain management, which is bizarre to even think about, right? Mm-hmm. And the little bit of training that they do get is focused on prescribing medication, not about what are some other methods that can be used. But now, so our country is in this opioid crisis, partly because initially, these opioids, they were meant for acute pain and they were great for acute pain. But slowly they became to be prescribed for persistent pain and over a long period of time. And we know that opioids are not effective to dealing with chronic pain and actually eventually lead to higher pain levels. And so you need more opioids and it makes the problem actually worse. So the CDC then, the Centers for Disease Control and Prevention, issued guidelines to reduce opioid prescription rates, basically, and said that non-pharmacological interventions should be instead tried first, or at least together with opioid tapering. But what has happened is that has resulted in quite a significant drop in opioid prescription rates in this country, which is wonderful. But at the same time, patients are not giving options for alternative pain management. They're not prescribed those kind of options. Insurance companies might not reimburse them, but more importantly, they're not even given the information. Mm. And bringing that to music, a story that really that continues to stick with me and our research team is when we do our studies, we almost always do mixed methods research. And so at the end, we interview the participants about their experience of how music therapy helped with their pain management. And it is absolutely amazing how many people will say that they have tried to taper, but they never received support before. How many people also say that they listen to music all the time, but never would they have thought that music could be used purposely for pain management. And so we hear these things repeatedly. So it is exciting that more attention is being paid now to non-pharmacological interventions, at least in terms of research being done, and specifically that there's now increasing amounts of funding available to specifically look at music for all kinds of health conditions, but often with chronic pain being a priority area.
So let's talk a little bit about how it's used strategically by music therapists. I mean, you know, as you mentioned, a lot of people listen to music. A lot of people even use it to soothe themselves, or, you know, even in, you know, people who are going into labor have a playlist that they bring with them to the hospital with the intention of minimizing the pain and getting through it. But music therapy is different. So tell me a little bit about maybe what are some of the types of music therapy interventions that are most helpful in these cases?
Well, I'll tell you that we don't have enough research to be able to determine specifically what is most helpful, but I'll tell you that in the research that I do, the protocols that we use typically take a multi-pronged approach. One, we really look at chronic pain as a very complex phenomenon and so to address it as a very complex phenomenon in the music therapy sessions. What that means is that we don't just use in the music therapy sessions music for relaxation or music for distraction, but instead really work psychotherapeutically with the patients to explore and work through and try to address major life stressors that they're going through, major, existential crisis that they might be going through because of the chronic pain and because that really has impacted their ability to keep a job or their ability to take care of a family and so on. So there's so many psychosocial stressors and complexities that come with living with chronic pain that needs to be addressed, because stress is a major amplifier of the experience of pain. Pain never lives just in the body, right? Pain is a perception in the brain that is influenced by all these psychological factors, including stress and emotional experiences, as well as biological factors, as well as social factors. So in our sessions, we really try to work psychotherapeutically with patients. At the same time, we do teach them self-management techniques to use at home. And those are often based on music-guided relaxation or music-guided deep breathing. So it often involves music listening at home. But we also encourage patients to engage in active music making, humming and singing along with the music, putting on a good song while they have to do a chore that they have a hard time doing because of the chronic pain, using music to motivate themselves to be able to wake up in the morning or get out of bed in spite of significant pain. And then the third part of our protocol is psychoeducation, really helping patients understand what about music can help with chronic pain. How does music affect the brain? How does music affect certain factors that might be exacerbating the pain experience? And I think it's that packet of those three major approaches that we find to be very helpful.
Maya, I wonder if you might talk a little bit about if there are any contraindications for using music. As someone who's worked a long time with people with PTSD, I think that population in particular is one that has suffered from interventions that can actually make the PTSD worse and induce a reaction or a negative experience. So do you have any sense of what are the cases in which people need to be careful, especially if they're trying to use music outside the guidance of a board-certified music therapist?
I think there's two main things that I think of. One is if they have certain sound sensitivities, whereas having just the sound of music is going to bother them. That can be with any population, but that's something that we're careful of, not to exasperate that by having them just be exposed to sound when that's not a comfortable experience, or where they have hearing issues that might somehow make it uncomfortable. But there's also the associations with music. So we're very careful to talk about if there's music that brings up triggers with PTSD or brings up bad memories or associations, then number one, we don't use it in a session unless we're trying to work through some sort of trauma narrative together in a very supportive environment. But absolutely not to listen to it on their own when they don't have the support around them to kind of work through that. So, with veterans, music is used a lot in deployment. So there are some research articles of qualitative studies where veterans talk about the way that they would use music to kind of get ready to go out and fight or to amp them up. And then they had negative associations with that after, once they came back. So you don't necessarily want to put them in that place again. Another example is, someone might be feeling sad and they want to listen to sad music, which is just going to bring them further into the sadness or into an expression of the sadness, which might be good in a therapy session together. But when you're by yourself, you don't want to go further into that space.
Yeah, I mean, there are times also where you've got to get things done. And if you go into an emotional state where you can't think of anything else, of course, that's not helpful, especially as we're talking about, living with chronic pain and actually living as opposed to just surviving.
Right.
I wonder if you could, Joke, tell us a little bit about the challenges in terms of understanding the effects. I mean, it's already difficult to measure pain and a person's response to pain. That already is fraught with subjectivity. And, as I mentioned, there aren't easy biomarkers. And here you're layering on music therapy, which is also, in its effects, can be broad and qualitative and meaningful, but not always easily lending itself to a kind of quantitative assessment. So I wonder if you could talk a little bit specifically about how you measure the impact, since, especially you've been successful in getting NIH funding, and, how does that work?
Yeah, it's an excellent question. I do, if I may, I think I take a little bit of issue with the word fraud, when measuring pain is, because it's subjective. I think it's important to maybe reframe that and to acknowledge as researchers that pain is subjective. And so therefore, what the patient says their pain is at a given moment, that is what it is. And we don't question that. But I understand your question is, and so how do you measure that? And then how do you deal with that in a research context? You actually touched upon that at the beginning of the conversation, where you said that you learned from this one book that you read, or this one doctor that you spoke with, that it's not always about pain intensity. So that pain intensity might not get better, but that people need to be able to live their life to the fullest in spite of the pain. And that realization has come decades ago in the chronic pain research world. And so the recommendation really has been to not focus on pain intensity per se in the as a target of the intervention, but also in how we measure the outcome or the impact of the intervention. But instead to look at how does pain interfere with one's ability to do things, to function, to enjoy family activities, not only attend, but actually enjoy, social activities. So that concept is called pain interference. And that has been a major or a primary outcome in the research that I am doing, is really looking at pain interference. Are we able to reduce the interference of pain on somebody's ability to live their life to the fullest? And in addition, another concept we measure in all of my studies is pain-related self-efficacy, which has to do with one's belief and kind of confidence that they'll be able to manage their pain or be able to do things in spite of the pain, or that they'll be able to prevent the pain from escalating or getting much worse. So have they learned strategies? Do they feel they have some kind of control? That's a big word, but some kind of control over the pain, and do they feel confident that they're able to do this? So those are two major outcomes that we look at. So rather than asking somebody, can you rate your pain on a level from 0 to 10? Quite honestly, we still include that in our NIH studies because many reviewers expect you to and want to see kind of these pain intensity measurements. But for us, it's much more important to ask, what are you able to do What about your activities that are important for you? Are you able to do these? And to what extent is pain interfering with those? And those, I believe, are much more important outcomes to look at.
I wonder too if there's some way in which sleep can be considered, because I know for a lot of people, in pain, sleep is disturbed, and that has a whole cascade of events or consequences. Do you ever look at sort of, and also I know that music therapy, or at least I should say music, can be used to help you relax and maybe improve sleep. Is that a possibility?
Yeah, I'll tell you, in the NIH study that we just completed, we had not included pain as a major outcome, but one person on our research team really, who was added to our research team later on, said we really should be looking at sleep. So we included that. We haven't analyzed the sleep data yet, the quantitative data, but in the qualitative data, we have quite some people who commented on that when we asked them, about their experience of the music therapy sessions, in what ways it might have helped them or not. Many patients do talk about sleep and say that at night they now use music strategies that they learned in the sessions to fall asleep rather than taking a pill bottle. And yes, you're right. I mean, that really comes into play, right, in pain management. I think we can all relate to when you had a bad night and you wake up and you have maybe a lot of other stressors going on in your life, your tolerance for pain is going to be much less. Even a little bit of pain is just going to put you in a bad mood. And the more you're in a bad mood, the worse the pain gets. And so you get caught in this vicious cycle that the worse the pain gets, then it's going to be harder to fall asleep or get a good night of sleep. And so, yes, those absolutely feed into each other.
So do you have any advice then, with your experience, both getting grants from the NIH, completing them, and being a reviewer, for people who would like to get some funding? First off, within the sort of realm of pain or pain management and music therapy, what do you think are some of the areas that remain understudied, and what can people do to make sure that they write the best possible grant?
Excellent question. Very complex question, of course. We actually just had this past summer, spring and summer last year, I guess, a series of webinars that NIH put on about trying to improve the quality of grant applications for these music and health related funding opportunities.
And those are available on our SHN YouTube channel. So in case
I saw that is wonderful. Yeah, thank you for posting that there. Yeah, I think a couple of things. One, to be very clear when you write these grants, what your kind of theoretical framework is. So how are you viewing how music therapy helps with pain? So it's not sufficient to say we are going to use music therapy, whatever that might be, to reduce pain intensity. Well, what kind of interventions would you be using and why? And so a theoretical framework can help explain why you believe certain aspects of music therapy or certain approaches, certain interventions can be helpful. So in my grants, we really explain pain from this biopsychosocial perspective, and then we explain how music and music therapy can help address factors in each of those three main areas. In addition, a theoretical framework will then help you articulate which outcomes you should be looking at. So I would say, to work with a research team who has been with some people who have written grants so that they kind of know what reviewers are looking for, and theoretical framework, articulation of theoretical framework is very important. To make sure that you have some kind of track record of successful funding. So don't make your first funded project an NIH funded project, but instead start with some small funding, maybe through foundation or through your setting or your institute, and do some preliminary work with some small funding so that you can demonstrate that you can bring a project to successful conclusion, that you publish the results then, so that you also are productive in terms of the output that comes out of these research studies. Having some preliminary data, but I cannot underscore enough how important an interdisciplinary team is to help you put a good grant together. And then you learn from the reviewer comments that you get, and you refine. And, I think sometimes people say, oh, it's so hard for a music therapist or, to get these grants. And my question is always, do we know how many music therapists submit grants? And do we know if they resubmit when they don't get immediately a good score, or do we tend to give up? So I would say don't give up and keep on working on refining a grant idea and submitting it.
So to that end, I wonder if you could talk a little bit about what the mechanisms might be in which music is helpful in pain in particular. So, are we talking, you mentioned, distraction and maybe stress relief, but maybe there are can you talk maybe a little bit more about sort of other kinds of ways in which music can, we think, have its effects?
Yeah, it's interesting you ask, because one of the NIH studies we completed is a mechanistic trial looking at underlying mechanisms. And the reason why we actually wanted to do that study is because I think there is a misconception, or maybe the easy to go to explanation as to why music can help with pain and music therapy can help with pain management is distraction and relaxation. And I think that is true for acute pain management, and for sure it plays a role in chronic pain management as well. But as I alluded to before, chronic pain is so complex and has such significant impacts on one's ability to live life, and so therefore has all these psychosocial impacts, that just learning how to use music for this, or just using music for distraction or relaxation, is just not going to cut it. More needs to be done. And so we were looking at several potential mechanisms, and the one that actually turned out to be significant and seemed to have a major impact on the effect of, or to explain how music therapy helps with chronic pain management, is that concept of self-efficacy. So what we found in our trial, in our trial, by the way, people were either randomized to a 6-week music therapy intervention protocol, or a 6-week active control protocol, in which participants met with therapists for verbal sessions, but the therapists were instructed to only provide some reflection, summative comments, but they were prohibited from offering any therapeutic interventions. And what we found is that both kind of sessions were very helpful, because overall to patients, because patients described that they don't have the luxury of having somebody in their life who can just sit for an hour to listen unconditionally and supportive and in a non-judgmental way to their pain stories, or to talk about their life stressors and how that might impact their pain. But what we found in terms of the difference between the two types of interventions is that only the music therapy participants clearly showed an increase in that pain-related self-efficacy. And so a control participant at the midpoint of the protocol showed much less of an increase in pain-related self-efficacy. And then by the end of the intervention, by week 6, showed a higher pain intensity, actually, and higher pain interference than music therapy participants who showed midpoint already an improvement in pain-related self-efficacy, and that then resulted in less pain and a much less pain interference. So it shows to us, and this is not the first trial that shows that. My prior studies have also shown the importance of pain-related self-efficacy in terms of that clearly showing that music therapy has a major impact on that. And other researchers have shown that as well. However, I think this was the first trial to really examine the mechanistic pathway, the mediation pathway between the music therapy intervention, self-efficacy as a mediator of then subsequent pain intensity and pain interference.
Maya, I don't know if this is all new to you in terms of this mechanistic explanation, or if there's something that you were already aware of, or even perhaps observed in your own clinic. But I wonder if you could speak to how you think music therapy might improve self-efficacy.
That's a great question. And I wanted to say first that I love, Joke, that you're doing these studies that are looking at the mechanisms, because we really need them. And I think we're just starting to get to the point where we can do them. And I have not done any mechanistic studies, so I can't speak from my research experience, but I know that when we're working with patients using music and imagery, one of the ideas is that we are working to activate their inner resources. And this is kind of like their strengths that they may be aware of or may not be aware of at all. So activating those and using music to enhance those. And then that, by activating those and enhancing those, then they have a different perspective of what they're capable of in terms of being out in the world or in their daily lives. So it's kind of like unveiling their superpower, or putting on their superpower so that they can face adversity. And this is a type of self-efficacy, right? So this improves their ability to feel like that they can go out and face what they need to face. So in music imagery, the idea of activating inner resources is a really important first step. Like Joke said, she was seeing, I know she wasn't using music imagery per se, but there are other ways in music therapy that happens as well. For instance, with live music making, there's also this idea of mastering a skill, and that has to do with self-efficacy as well. So that she saw it early on in the study, the self-efficacy being activated. I think it's important as an early process that's going to then be able to stay with them and affect their improvement in their care. She may have more idea about the live music. Yeah.
Yeah. So yeah, we do use a lot of interactive kind of live music making, but I'm so happy you brought up that idea of inner resource, because that is something we emphasize a lot too, that it is not us music therapists telling participants, this is how you should be using music, or this is a kind of music that you should be using. I get that question all the time, by the way, when I speak about this topic. What kind of music should we tell our patients? Doctors ask us all the time, what kind of music should people be listening to? And it, of course, Maya knows the answer to this. It all depends. It really is the music that is meaningful and impactful for that person. So people are already using music as a resource, but I think what we can help show or help them understand is then how to use it more purposefully to help specifically with addressing some of these factors or underlying mechanisms that might be amplifying pain. So it's not so much listen to music and the pain will be better. No. Let's look at what are some things in your life that seem to be amplifying your pain, that seem to be making pain worse. And now, what kind of music do you like to listen to? Why do you like to listen to that? Give them experience of how active engagement with music might even strengthen other creative inner resources that they might be having, and beginning to kind of put those building blocks together. These are things that you are already doing or that you can easily do. And actually in the qualitative data of both of our NIH trials now that we just completed, participants commented on how easy it was to learn to use music for pain management and how accessible it was. And what I was really struck by is that several participants mentioned specifically that the reason why they liked music therapy and how they were able to use it at home is that they could do it together with their family. They said it doesn't have to be, sometimes I want to do it by myself for my self-care, but it's something I can do with my kids, or it's sometimes something I can do with my spouse. And so it becomes something that the whole family can engage in. And now it's not only the participant feeling empowered to be able to do something, but the family also feels that now jointly they can contribute to a person's ability to manage their pain better. So we haven't actually looked at that specifically in our studies. These are now just things that are coming up in the qualitative data, but that I would be really interested to look at in future trials.
And I think a lot of tech companies are really interested in this personalization of music. One that I work with in my lab, uses heart rate variability as a measure of stress, and then compares heart rate responses, excuse me, to music and from a streaming playlist, and then figures out what features of music are more likely to, for that individual, move that needle up and down. And I can imagine cases in which we get to this place where, with the collaboration of a music therapist, in fact, we're working with one now, you kind of then, help even use some of these physiological markers or these biomarkers to really specify the prescription of music that they're listening to. I want to let our viewers know who are live with us that you're welcome to post questions in the chat. And we do have one from Joe. So Joe is asking, what science journals publish this line of research? Where can people submit it?
Where they can submit it or find it.
Or read about it, yes.
Maybe both. Yeah, I think that it's actually an excellent question, because certainly for music therapists and music therapist researchers, it is so important that we don't just publish in our own professional journals, but that we publish outside of that. So I have published my work in oncology journals, for example, in supportive care and cancer. There are certainly a lot of other science journals that a very large number of science journals that have published music therapy research, and also research that is being done by other healthcare professionals, so such as nurses. I have done several Cochrane systematic reviews, and one specifically focused on people with cancer. And oh my goodness, yeah, the publications are all over the place, certainly not just in journals of music therapy, but oncology journals, cardiology journals, whatever whatever the population is that was the topic of the study, or participants in the study. But I think it brings up a really good point that we need to make sure that we publish this kind of research outside of the fields of music therapy as well.
And that's for people who want to read some of these papers at the Sound Health Network. One of our major projects is to build a clearinghouse of publications, especially of people whose work we feature on our webinars. So both Dr. Bradt's and Dr. Story's publications are now on our clearinghouse, which you can find at soundhealth.ucsf.edu, and just go to the clearinghouse button. Elizabeth is asking, she's curious, or they're curious about your take on music therapy for acute surgical procedural pain. They say that in their experience working in an ICU, those experiencing acute pain are easily overstimulated and not receptive.
Yeah, I don't know, Maya, how much work you have done with acute postoperative pain with music listening. I don't want to be out taking all the questions. So.
No, go ahead. I haven't done any, although I've read quite a bit of the literature on there. And there is a lot of literature on using music for acute pain.
Yeah.
But also, music listening that isn't music therapy, but just ways of music being supportive in those situations. But Joke, maybe you've done some work in that area.
Yeah, we just recently completed a study looking at brief music therapy intervention specifically to teach people who were to undergo a total knee replacement for how to help manage their pain following the surgery. So what we did is the participants in the study met with the music therapist actually prior to the surgery to learn some very basic self-management techniques. So this was now not psychotherapeutic work. It was really understanding what kind of music do you like to listen to, and how can this music help you for different kinds of pain management strategies. And we taught these interventions ideally about 2 weeks prior to the surgery, so that the patients actually had time to practice them at home, such as music-guided imagery and some music-guided deep breathing. Then after the surgery, patients actually received an MP3 player with an individualized music list on there, as well as some music that we had composed with some voiceover tracks to help patients use this following the surgery. And this was just a feasibility study, so a really small study. But what we did found is that patients who received the music therapy versus those who did not consistently reported lower pain intensity following the surgery than control participants. Mm-hmm. And we were interested also in looking at opioid use. And a lot of studies, especially studies by nurses, have looked at music listening, for acute pain, postoperative pain. But unfortunately, they're only looking for about maybe 1 or 2 days following the surgery in terms of pain medication usage or pain intensity, and not more long-term. So we were interested in looking also at a longer-term outcomes. But to the question about sensitivity, I think that is exactly what a music therapist can come in. So rather than assuming that everybody will be able to listen to music, when you're in extreme pain, yes, that might be overstimulating at that time, and to help people understand at what time points they can use the music. For example, to not wait until the music is so severe, but to actually use music to keep the pain from being amplified, especially you probably know, Indre, immediately after the surgery, you get your pain medication and then you have to wait your 4 hours. And so let's not wait till hour 3.5 to start thinking about some strategies to use because the pain is getting severe and you so badly want that next pain medication. But let's start using music earlier on so that you can prevent from going to those peaks each time.
I also think it's really, the self-efficacy piece makes a lot of sense to me, because I think that often one of the things that happens when you're in pain is fear of more pain, and the fear that the pain is going to get worse or unmanageable sometimes is more debilitating than the actual pain itself. And I think that if you feel like you're more in control, then maybe that somewhat makes the fear, mitigates it a little bit. Is that true to your experience?
Absolutely. Absolutely. There's, again, that sense of control or feeling helpless is another major amplifier of the pain experience. So the more you feel like confident that you'll have some control over it, that you'll be able to do something when that pain starts getting worse, plays a major role in how you will perceive that pain to be.
So Barb is asking if you can comment about music therapy intervention fidelity. So I'm imagining you know what that is. Maybe you could tell me, because I don't. Other than maybe I'm assuming it means that if you go from one place to another, that you still have the same results. And any plans for translational research?
Yeah, in terms of treatment fidelity, so within our studies, we of course pay very careful attention to that, as we're using several music therapists, so to make sure that everybody delivers the intervention as intended. Yet at the same time, music therapy, especially in the work that we do, we use a lot of, in my lab, we do a lot of interactive music making, improvisational music making in the sessions. So that is not, of course, purely prescriptive. There needs to be a flexibility of what it is and that music therapists can do to respond to the in-the-moment needs of a participant in a session. Yet we have treatment protocols that do describe, essential components that have to be present in a session, things, prohibited components, things that cannot be present in a session. For example, not in a 45-minute sessions, we don't want therapists to talk for 30 minutes. There needs to be a really active use of music making. The 3 components I talked about earlier need to be present in each session. And so we do have a protocol in all of our research studies, and then we do have treatment fidelity scoring procedures where somebody will listen to the recordings and then rate the delivery of these interventions to make sure that they're delivered with a certain level of fidelity. And that is really important, because otherwise, so right now our NIH studies both have very exciting results, which we hope to publish soon, but what use is there to having a study that have exciting results if we cannot then describe with some certainty what it is that the music therapist did? Because otherwise it doesn't have indeed any translation or implementation power, right? So if we, that's what I was alluding to before, if we just describe music therapy as music therapy, then what is the next person going to be able to do with that? How are clinicians going to be able to use that research? So it is so important that we indeed have some kind of measures of treatment fidelity and then carefully describe what was done in the sessions so that people now can apply that to their practice.
Maya, I think a question for you, perhaps, although Joke, feel free to jump in as well. Ashley is asking, when patients are having acute or chronic pain and they've been referred to a music therapist, but they're resistant because they don't know what music therapy is or what to expect, what is your approach? This probably maybe even especially true in I mean, I'm just assuming now, but in the veteran population, where maybe there isn't, although maybe in that population they're well aware of music therapy. I don't know, but I can imagine that this is something that you face quite often.
There is quite a bit of creative arts therapy across the board in the veteran medical centers. We have about 125 creative arts therapists across the country, and the majority of those are, the largest number are music therapists and then
Wow.
art therapists. But 125 isn't a lot when you think of how many VA medical centers there are all across the country. But also, I would say that veterans as a population sometimes are very serious, want to get down to the work, type of individuals. So I often hear like, "You're not going to make me play those instruments, are you?" Or "You're not going to make me draw as part of this." So kind of a fear of the creative process and not being able to engage in that element of self-expression. So there needs to be a time of building trust and rapport before they're able to do that. And I feel like one of the best things is by getting to know them musically. So getting to know, having those conversations about not only what kind of music do they like to listen to, but how has music been used in their life? What's a song that they would play when they were 16 and rebellious, or when they were 18 and going out on their own, and getting to know them in that way is a way to kind of gently talk about music and listen to music before having yet, while you're building that trust that may be required to engage in the creative arts in a little more in-depth way, or asking them to play or to draw, something like that can be threatening.
Yeah, how do you handle the sort of the skepticism that you might get from a patient who, especially if they're in pain? I mean, they're probably, already not super tolerant of, things. I mean, I know that when I'm in pain, I'm very irritable, and it's hard. I mean, do you have any strategies? I mean, I can see how sort of just talking about, music is a conversation piece that we use all the time. You go and to a cocktail party, and often music is a topic of conversation. But is there anything else that you want to add to sort of the in particular individuals who are in pain, who maybe don't have as much appetite for getting to know someone else?
Yeah, I think that when I'm working with people that are in chronic pain, and I'm doing, I do individual sessions, so it's individual work, there has to be a willingness and a motivation for them to show up and want to be there. So that kind of takes care of a lot of that right away. The people that are in a situation where they feel like they can't show up and participate usually don't come. But music is a pretty strong motivator. So I think we have a pretty high retention rate in our studies, and people show up and want to be a part of the study. And it's not just, I see that talking about music can immediately relax people into the conversation, as opposed to talking about their pain or talking about their life or details of their life. They can talk about music. It's kind of a more neutral ground. But another thing is just listening to music together. Even like, introduce me to the music that you listen to for pleasure, that you just listen for pure fun, and let's listen to it together. And that's not very threatening.
That's the beauty of having the, jukebox at your fingertips, where you can pull up, they say, I like the song. Okay, well, let's listen to it. Even if they are not able to have a conversation at that moment. I can see how that would be powerful. We just have a couple minutes left, and I wonder if you might talk more about the sort of this movement forward away from opioids, away from just taking a pill, and what that might mean for reimbursement and for people's ability to pay for these kinds of interventions. You've both made the point very clearly that having a board certified music therapist guiding this process is incredibly important and can have major benefits, but for a lot of people that's expensive. And so I wondered if you could speak to where we are in terms of health insurance companies covering those costs, or other ways in which more people can benefit.
Yeah, I think unfortunately a lot of music therapists, I think, are working with people with chronic pain, whether that's a primary focus of their practice or not. No matter where you work, you will encounter people with persistent pain because it's such a prevalent problem in our society. But unfortunately, we have not been doing much research in this area. So there's quite a bit of research on music for acute pain management, but it's finally beginning to improve, but we just still need much more research, certainly larger randomized controlled trials, and then looking at some of these economic factors. In one of the studies we did with the cancer survivors, we actually found a large effect, meaning music therapy had a major impact on the opioid tapering process. So people ended up using much less opioids when they received music therapy. It was a small pilot study to begin with, but it's very promising. And so we would definitely need to be looking at the economic impact. But it's interesting you actually bring that up as one of our final talking points, because one of the we interviewed physicians also, prescribing physicians of participants in our study. And one of the physicians said that some of their patients brought a concern to them when they had been approached about participating in this study, saying, I would like to do this. I want to taper my opioids, but I'm concerned because after 10 weeks, this was a 10-week intervention study, that intervention is not going to be available to me anymore. And I will have tapered my opioids, maybe not completely, but I will have tapered them. And I will be left without this intervention because I will not be able to afford this. And so it's a real fear then for people to even enroll in a tapering study if they're not going to have the non-pharmacological intervention available to them afterwards. Of course, at that point, they did not know yet that they would learn self-management techniques, have improved self-efficacy, but that is a major concern. And so I would say we just need much more research to be able to show the actual economic impact. And I think that's what will make insurance companies be interested.
Well, I encourage you to, as our listeners, as members of our network, to look through our clearinghouse for papers related to these topics and watch the NIH videos that will help you write those successful grants. And of course, if you're an individual who's suffering from chronic pain, where can they find music therapists? What is the best place for people to look for them, other than our directory, of course?
I think also the American Music Therapy Association has a directory where they can find music therapists there. They can search by state or regional area in order to find one close to them.
Great.
Yeah. And I believe also the board certification of music therapists website has also a locator where you can find music therapists in your area who are board certified.
Great. And if you are a music therapist, please do add yourself to our directory so that people can find you. Joke and Maya, thank you so much for sharing your thoughts and experiences with us here at the Sound Health Network. We so value your work.
Thank you. Thank you for having us.
Yeah,
and
thank you so much.
For participating in this webinar. To learn more about the Sound Health Network and to take advantage of the resources we offer, you can visit our website, soundhealth.ucsf.edu. And you can engage with us on our social media accounts at SoundHealthNet on Twitter, Facebook, and Instagram, and watch archive video on our YouTube channel. See you again soon.